In this video we demonstrate an anterior approach to retracted anterosuperior cuff tear with biceps SCR and subscapularis release and repair with transosseous equivalent double row repair. Authors have no disclosure. The rotator interval is opened above the subscapularis tendon by the anterior portal as working and posterior portal as viewing portal. Coracoid is released of soft tissue from inferior and posterior aspect. We then shifted our 30-degree arthroscope to anterior portal for inline view of subscapularis tear along its tendon. The superior edge is then released between the subscapularis and the coracoid avoiding suprascapular notch. The anterior side of the muscle is exposed by releasing the conjoint tendon from the pectoralis major by clearing the clavipectoral fascia. Behind the conjoint tendon, the anterior side of the subscapularis needs to be released till the medial border of the subcoracoid bursa, marked by a pellucid barrier forming the outer envelope of the plexus and its branches and the axillary vessels. Further release is done by alternating anterior and posterior surface release and begins by placing a traction suture onto the subscapularis and applying traction in line with the subscapularis through anterosuperior portal. Release begins from the joint face forward, to avoid risk of neurologic lesion, as the muscle is innervated on the anterior side. Dissection continues down and inward, to visualize the axillary nerve following which the subcoracoid bursa can be resected without risk of neurologic damage. This part of the procedure is often hemorrhagic, requiring a hemostasis device. Any adherences are released intraarticularly, between the subscapularis and the IGHL. Finally, the posterior release is performed to break up adhesions between subscapularis and glenoid neck. The subscapular insertion is cleared of soft tissue without decorticating the lesser tuberosity to preserve pull-out strength of future anchorages. After mobilization we medialize the attachment site up to 5 mm by creating a larger footprint. In view of the large complete tear that extended into muscular insertion, we used one triple-loaded tape anchor through the anterior portal at an appropriate angle to the lesser tuberosity, and each suture strands were pulled out of the anterolateral portal through a cannula and shuttled through the tendon using suture passing device, maintaining the pull using the tension suture applied. The sutures were tied using standard arthroscopic knot through the anterolateral portal over the anterior aspect to prevent cut-through, and the repair is completed by passing the sutures through knotless anchor placed over anterior aspect of greater trochanter. Once subscapularis repair is completed, attention is given to delineate the supraspinatus tear along with subacromial decompression to make ample space for easy use of suture passing devices. Biceps tenotomy was done at suprapectoral level through mid-axillary portal as working and anterolateral portal for viewing. An Ethibond loop stick was taken on the cut end of medial segment of biceps for applying traction. We placed one triple-loaded all-suture anchor and another one double-loaded all-suture tape anchor as medial row just lateral to articular margin where pull-out strength is more. One suture strand from anterior anchor was used to make sync loop through cut end of medial segment of biceps, and other strand was passed and both strands knotted such that biceps is placed flush in the trough created. The sutures from biceps tendon were further passed to supraspinatus, followed by passage of all other sutures from medial 2 anchors to the anterior part of supraspinatus. Similarly, a second double-loaded tape anchor was placed 5 mm posterior to anterior anchor, and tapes passed through the posterior part of supraspinatus using suture passer. The bone bed medial to medial row anchors were decorticated and microfracture done along with tuberoplasty. Supraspinatus footprint was also medialised by 5 mm in view of retraction. All sutures from both anchors were knotted over the muscle, and anterior strands and posterior strands were grouped and crossed to fix into 2 lateral row knotless anchors as in transosseous equivalent double row construction.